very important issues related to patient-doctor relationship in oncological care and dramatic developments that pose threats of moral and ethical nature. And today we'll see many important seminal questions as well. You know that the issue of systemic oncological care has been vividly discussed in Poland, and it's become a political issue at one point, and it really deserves notice because cancer care in Poland has big economic, social and systemic impact, and we've been working on systemic solutions in Poland, but you can also see examples from other countries, and you can see today we'll have a chance to see, get to know the first cancer plan in Poland. It was developed by Professor David Kayat, who was kind enough to accept our invitation, and he'll talk about the first phase of the plan, 2002 and 2007, and he'll also explain how it is being developed so today. And Professor Kayat, when he was working on the plan, paid special attention on the elements of the system to make it effective. It's not only patient care, but it's also the number of pathologists, oncologists. This is the development of medical centers, hospitals, outpatient clinics. So, Professor David Kayat, I think it will be very valuable lecture. We are at the stage of creating systemic changes in Poland.
My dear colleagues, it's really a great pleasure and a great honor for me to be here in Poland, since it was the place where Marie Curie was born, and you know, for us in France, she's one of the main person in the field of cancer. So I'm going to talk. Can I have the pointer, please? Thank you. I'm going to talk to you this morning about what we have done when we have set up the French National Cancer Plan back in 2002, 2003. But I think that in order to explain you why we did this National Cancer Plan and how we did it, I think it is important to come back to the main question, the most important question, to my point of view, maybe the single most important question. When we deal with cancer, when we try to understand how can we control this disease, terrible disease, the first question that comes into our mind should be, is there anything more important than the patient in cancer? And you may think that the answer is obvious. There is nothing more important than the patient, the human being affected by cancer. But I can tell you this was not the case just 20 years ago. When I started to be an oncologist in the early 80s, I can tell you that at that time, the patient did not exist even. We were not asking any question to the patient. We decided for the patient. We decided what to tell to the patient, what kind of truth. We decided to remove the breast, to remove the laryngeal, to remove whatever, without asking the perception of the patient, what the willingness of the patient, how they feel with the disease. They were threatened, they were vomiting, they were losing their hair, they were losing their jobs. And at the end of the day, most of them were even losing their lives. So things have changed, and I think it is very important that we can now today consider that question as the main question. Is there anything more important in cancer than the patient himself? And I think that things have changed very much 15 years ago. In 1999, with some of the greatest oncologists in the world, including Professor Gabriel Ortobaggi from MD Anderson or Peter Harper from London and so many others, we were just thinking that we were coming to the celebration of the millennium, and there were several celebrations that were scheduled all around the world. And again, we thought that during this celebration, again, we will forget, we will lose a unique opportunity to say hello to all these patients, to show them that we consider them as something important, not trivial. All these millions of people affected by cancer. And so we decided to write what has been called the Charter of Paris or the UNESCO Charter Against Cancer. And I convinced President Jacques Chirac, was president of France at that time, and I convinced also the General Director of UNESCO, Dr. Matsuura, to sign that charter, and that charter became the UNESCO Charter Against Cancer. And this was signed at the Élysée Palace. This is a picture of the signing on the 4th of February 2000. And at that time, this charter became the UNESCO Charter of Cancer. There was 10 articles in this charter, and we're going to look at them very rapidly. But the first one was the most important one, was the most political one, was that the Article 1 was just saying that a cancer patient right are just human right. Because it looks like it's difficult to understand today, but even 15 years ago, a patient with cancer was not considered anymore as a normal human being. If you have a heart attack and you get stents on your coronary arteries, after you finished with that process, you're still a human being, normal. Nobody is going to tell you that you have had a heart attack every day of your life. Your husband is not going to leave the house. You're not going to lose your job. But if you got breast cancer, your husband might leave you. You might lose your job just because you will always be considered as a cancer patient, no more as a human being. So this was why we thought it was so important to remind everybody about the fact that cancer patient rights are human rights. Now, when we start talking about cancer to our politicians, what I did in 2000 and later on to convince French government to do a national cancer plan, we give figures, we give numbers. Like in 2012, there's been 14 million new cases of cancer in the world and 8 million deaths. These numbers are so big that, to my point of view, when you speak about this, when you tell these numbers to your politician, to your government, they completely lose, they are meaningless. They lose completely their meaning because they are too big. How can you deal with this number? Is it a lot or is it not a lot? Is it more than AIDS or cardiovascular disease? And the political meaning of these 14 million new cases, you should not, or 8 million deaths, you should not consider 8 million deaths, but you should consider 8 million times one death. 8 million times one colleague at the work that you see coming one day very tired, a few weeks later coming without hair, and a few months later not coming anymore because that person has died. It's a seat around the table that will stay empty forever. It is the door of a children's room that you close and will never open again. And if you understand that 8 million times that, you understand what's the meaning of such a terrible disease such as cancer. And this is why cancer is not just a simple other disease. It is very much associated with stigma. Everybody affected. I mean, if you say somebody you have a heart attack, we said, okay, there's no problem. I might be cured. If you say somebody you have cancer, then it's desperate because cancer is not just considered as a biological disorder, as another disease, but it has so many stigma, like fatalism, like defeatism, like the fact that you don't believe anymore in the future of your life. And because of these numbers, because of these fatalism and stigma, cancer is not just a disease, it's also a political matter. And when we come to the idea that it is a political matter, the most appropriate level of work to fight against cancer has to be political. Then it will be medical, scientific, social, research, whatever. But it has to be considered that the appropriate level for fighting cancer, which is a political matter, is a political endeavor. So then we come to National Control Cancer Plan, which is NCCP. What is an NCCP? In fact, it's very simple. And I know that in Poland you are very much working on your National Cancer Plan. It's a set of measures that just are coordinated, evaluated by an independent body, that are very well funded to be credible, that should integrate all stakeholders and with the promise to give, on a very regular basis, reports to the public. So if you look at that slide, you can see why to fight against cancer, I think it's this one, why to fight against cancer, you have to consider all aspects of the war on cancer. Scientific, by defining new targets, finding new treatment. Medical, there's so many deaths and so many premature deaths. You know, in my country, cancer is the first cause of death, and it's about 39% of premature deaths before the age of 65. So really taking out of life these people that are still producing. Economical, because of the potential years lost, or years of life that can lost. The cost of care. Social, because of exclusion, discrimination, and stigma. And also, the prevention of cancer is very much related to some very well-defined preventive measures, such as tobacco. So it's political to limit the access to tobacco, to increase the price of tobacco, to ban the smoking in the public place. If you look at alcohol, taxes on alcohol, forbidden campaign for alcohol, it's political. If you look at nutrition, you have to teach that at school. When they go to eat, all the children are going to eat at lunch. If you look at the physical activity, again, it's education at school. If you look at sun exposure, it's campaign media. And if you look at infection, it's vaccine access. So all these issues are political issues. They are governmental issues. They are not just single-person issues. And if you look at what I said, you can see here that looking at new targets and access to new treatment depends upon cooperation, about funding, and about education, high-level education. If you look at avoiding death and premature death, it deals with screening, with access to care, with definition of quality care. If you look at economical, you have to evaluate the cost and fund for the cost. And social, you have to vote loads for access to loans and access and back to normal life to patients. So all this is politic. So NCCP, why NCCP? Why putting all together this integrated set of measures? Because it raises awareness, political awareness. It gets all people committed, even people that were fighting before, like private setting and public setting, that can work together. And also because that you cannot defeat cancer if you don't defeat stigma of cancer. If somebody thinks that he's going to die because he has the diagnosis of cancer, then he is not going to fight. So you have to change the stigma by campaigning. Research, we have to promote high-quality research and support cooperation between researchers, whether they work in the private, public setting, university or not. We have also to define the best clinical practice and to promote quality care so that we will stop funding for care that are not going to improve the outcome of this patient. We have to work on prevention because the best way to defeat cancer is to prevent cancer. So we have to work at school, in the campaign, in the media, to help people to understand the cause of cancer, tobacco, nutrition, lack of physical activity, obesity, and so many other things. We have to, and that's most probably one of the most important articles, we have to look for partnership with patients. Nothing can be done without the commitment of patients. They have to understand what is the disease, how can we fight against the disease, and be really committed in that. And we as doctors, we as researchers, we as politicians, we as pharmaceutical company researchers, we should not look at patients as people that might be dangerous for our activity. They are partners. We have to educate them so that they can partner with us. The 8 is promote quality of life, not only in the beginning of the disease by more conservative treatment, but also at the end of life. Quality of life is until the last second of life. We have to look at maintaining the high level of quality of life, even in those patients who are dying, conserving the dignity of the human beings even when they are dying. We should promote national cancer plan. And the last article was saying the day of the signing of this charter was the 4th of February 2000, should become the World Cancer Day. And it became the World Cancer Day. Now, everywhere in the world, on the 4th of February, we speak about cancer. Let's come now to the French National Cancer Plan, 2003-2007. I was responsible for that. And it was a set of 71 measures dealing with prevention, screening, care, patient support, facilities, upgrade and access to innovative treatment, research, training, and everything. So it was not just attacking cancer by improving the care or by improving prevention. It was really attacking cancer by all the possible ways. We set up, and I was the founding president of the French National Cancer Institute. My budget to do this National Cancer Plan was 1.7 billion euro, over 4 years, and we created about 4,000 jobs, like oncogeneticists, like psycho-oncologists, like oncologists, like imaging specialists, and everything. So, one of the things that I'm very proud of about what we have done in this National Cancer Plan and in the setting up of the National Cancer Institute is that in the Institute, one of the most powerful committees, there are the research committee, the clinical care committee, and so on, but one of the most powerful is the patient and survivors committee. There is not a single decision that is taken by the National Cancer Institute without asking the opinion of those who are finally, ultimately concerned about what we are going to decide. I'm talking about the patients, the survivors, and the users of the healthcare system. So let me tell you about what I consider the 10 most important measures. It's going to deal with all aspects of fighting against cancer. First was on prevention, for instance. When I started, the price of a packet of cigarettes was 3 euros. When I finished, was 5 euros, so more than 60% increase, 200,000 less smokers in France. I signed a decree saying that it's forbidden in France to sell tobacco to less than 16 years old people, and we voted a law to ban smoking in public places. For screening, France was, and I think it's still the only country in the world where we have a national organized breast cancer screening system and a national organized colorectal cancer screening program, plus a one-day, free of charge, detection of melanoma by all the dermatologists in France, and a totally free access, unlimited access to pap tests for the prevention of cervical cancer. What's about another aspect? Prevention, screening. Now, when I started the National Cancer Plan, the budget of all hospitals, whether the public hospital, were a defined budget that the hospital was getting in the 1st of January every year. This included all the expenses for any kind of treatment, including the cost of anti-cancer drugs. The only drugs that were not included in that budget was the AIDs, the antiretroviral. For that, there was an unlimited budget. So our colleagues in infectious disease department, they could spend as much money as they want. The hospital will get the money back from the government. But for cancer was not the case. And if you think about what happened in the late 90s, early 20s, is that we had so many new drugs, what we call innovative drugs. I mean, I'm not going to give you the list, but so many with such a high price that usually in many places in our country, in France, since the months of September, October, the director of the hospital were coming to the oncology department and say, you know, you are out of budget. So no more Avastin, no more Erbitux, no more these expensive drugs. And we were delaying treatment, and people were losing some chance, and the outcome were not that good in winter than in spring. It's not acceptable. So one of the measures I took was to put this budget out of the budget of the hospital. So for anti-cancer drug, it was exactly like AIDS. We could spend as much money as we want. The only good thing was to give the best treatment to all cancer patients in my country. What happened? Obviously, the cost of these innovative drugs increased in an incredible way. When I started, it was about 300 million euro for these drugs in France. In 2009, we were above 1 billion already. So we had to find a way to control this increase. We cannot continue 2 billion, 3 billion, then the other disease will become, specialists will become very upset about that. Most of the money is going to cancer and not to the care of other disease. So one thing we did was that we decided to look and to be sure that those who are dealing with cancer patients, including those who are prescribing new drugs, were really people that have the skills and the knowledge, the capacity, the competence to treat this cancer patient. And what we did is that we did a survey in all the country, in all France, to look at which hospital, which doctors were taking care of these patients. And we found out something that was very interesting. It's a bit long for that slide, I don't know why. Well, I'm not sure you can read that, but I'm going to show you a slide which summarizes this one. For instance, we decided to look who is taking care of breast cancer in France. And here you have the 22 regions of France. 22 regions of France. And for each one of them, we were how many hospitals that were treating at least one case of breast cancer in 2004. And here, the percentage of these hospitals that were treating less than 20 cases a year. In 2004, less than 20 breast cancer. Not only for one doctor, but for the whole hospitals, usually 2, 3, 10 doctors, not only one. So can you imagine just less than 20, meaning usually if you think there are at least 2 doctors, that means 10 cases per doctor, that means less than 1 case every month. And if you want to summarize that slide, you can see that. If you put the threshold number at 20, which is the minimum level of expertise one can think of, if you look at that, the number of centers, about 1,000 centers in 2004 that treated at least one case of breast cancer, leading to 62,000 surgical acts out of about 5 million surgical acts. But this 62 is only for breast cancer surgery. If you look at the number of centers that did less than 25, it's 474, which is almost 47% of all French hospitals that were dealing with less than 25 cases a year. But hopefully, if you look here, these 47% of the French hospitals, public, private, teaching university hospital, whatever, altogether, these 47% were treating less than 8% of all the breast cancer cases in France. So what we did, we closed this hospital. We said, now, if you want to be allowed to treat a breast cancer patient, you have to get a state authorization that you get every 4 years, based on many things, including your demonstration and your evaluation about your minimum activity on that cancer. So every hospital, even my own hospital, which is the largest in France, has to get every 4 years an authorization by the Ministry of Health based on each cancer. So I might be allowed to treat breast cancer, but not prostate cancer or not esophageal cancer. And that did an upgrade in the professionalization of the management of cancer patients. Now we can be sure that those who are allowed to treat cancer today in my country are really experts because they do a minimum of activity. We, for social action, we voted a law that allowed survivors of cancer to get loans so that they can open a shop, they can buy a new home or whatever. And we also concentrated research, but this is another issue. So at the end of the day, 5 years after we did that, we had the feeling that indeed, fighting cancer is a political issue. And if you want to look at another disease that has been even more successful, much more successful than cancer, to make politicians understand that dealing with that disease is a political matter more than a medical or scientific matter, is AIDS. I don't know about the situation in Poland, but let me tell you the situation in France. AIDS was considered as the best model for how some patients, some specialists, can change the look at the disease from a medical issue to a political issue. So if that's the perception of the media and of the general population in my country. If you ask questions about what's the difference between AIDS and cancer, first question, about the number of cases. People in the streets think that AIDS is everywhere, a huge number of cases, whether cancer is relatively limited number of patients. That's totally false. Cancer kills more in the world today than AIDS, plus tuberculosis, plus malaria altogether. If you ask the second question, people usually tell you, you know, cancer kills all people, so all people have to die. So it's not that important whether AIDS is killing young people. But that, again, is wrong. It's totally false. Because cancer is the first cause of death and the first cause of premature death in developed countries, such as France. And 50% of cancer, of the deaths of cancer, occurred before the age of 65. So relatively young people. If you look at, you know, they say it's acceptable to spend a lot of money for treating AIDS. But to treat cancer, we spend money for nothing, because in any case, these patients are going to die. So that's false again. And when I was at the head of the National Cancer Institute, I asked the Social Security, so a totally independent body, to make a study about how much it costs to treat the most important disease condition in France per capita and per year. And so we took different diseases, such as cardiovascular, diabetes, malignant tumor, nephropathy, HIV, rheumatoid arthritis, graft complication, and we asked the Social Security to look at how much it cost per capita and per year in France in the year 2004. And the average cost here is about it's about 7,000 euros per capita and per year for all these diseases here, 7,000 euros. When you look at cancer, is it true that cancer is expensive? No, cancer is here. It's just above the mean. So it's much cheaper than nephropathy, than HIV, than graft condition. Now, people are saying, okay, maybe, I was talking to the parliament on a regular basis to get the money for the National Cancer Plan. So, a deputy do not care about people dying or not. What they want to know is economical issues, how much money is going to cost. So the people were answering me, okay, maybe it's not that expensive to treat cancer compared to other big diseases, but the drugs are very expensive. Your drug in cancer is the most expensive drug. So we asked the Social Security to look at, out of these 7,000 euros per year per capita, what is the percentage of drugs within that cost? And the average is 20%. And if you look at cancer, malignant disease here, it's just 19.1%. So even if you look at the drugs, it's not true that's that expensive. It's just in the range of that. So why there is such a discrepancy between the truth and the perception and the political perception? The idea that treating cancer, in fact, is not that expensive and is not more expensive than treating any kind of significant disease. It is the perception that is expensive, not the reality. And the perception that it is expensive is related to the idea that it is not worthy to treat a cancer patient because of the stigma it carries. When a patient thinks that when he has been diagnosed with cancer, the life is finished, but the politicians think exactly the same. So if the life is finished, why should I spend that money to treat a patient? Whether even for AIDS, for nephropathy, for whatever, they consider it's good to treat, it's good to spend that amount of money. So it's the perception which is wrong about the cost of cancer. Let's continue. It said AIDS kills the poor people in Africa and cancer kills the rich people in our country. This is totally wrong. According to WHO, in 6 years from now, in 2020, there's going to be 20 million new cases of cancer in the world, leading to 10 million deaths. The problem is that out of these 10 million deaths, 75% will occur in countries that altogether today represent less than 5% of the world GDP, meaning that it is going to be the poorest countries in the world that in 6 years from now are going to lose, to pay the highest token tribute to cancer. So it's not a disease of the rich country, it's a disease of everywhere and mostly in the future of the poor countries. What's about the incidence? We are afraid that every day there's more AIDS cases, that the perception in the media that cancer is stable. This is absolutely true. This is absolutely wrong. If you look at the numbers here, you can see that cancer was 6 million in 2000, 10 million deaths in 2020. If you look at death, 10 million in 2020 versus 1.5 million in for AIDS. So cancer kills about 5 times more than AIDS. And finally, the last issue, the last question, maybe the one that summarizes everything, is that if you discuss with politicians, if you discuss with media, they think that dying from AIDS is unacceptable. But dying from cancer is normal. There is so many cases of cancer, so many cases of death by cancer, that finally we consider it's normal to die from cancer. And I say this is absolutely wrong. It's not an acceptable cause of death. So again, is cancer a political matter? In my country, it's going to be the conclusion. If you look at the balance between the burden of cancer and the expenditure for anti-cancer drugs, you can see that cancer is responsible for about 30% of all deaths in my country every year, and this number is rising, and about almost 40% of premature deaths before the age of 65. So leading to a huge loss of potential years of life. The average life life in my country is about, let's say, 80 years old. So when you die before the age of 65, you have lost a lot of potential years. And if you lose these years, you lose economical growth, because if you are dead, you cannot go to cinema, you cannot go to a restaurant, you cannot buy clothes or buy a ticket to go for vacation. And that's what we are looking for, economical growth. If you look now, what we are ready to pay to fight this first cause of death in my country and the first cause of premature death in my country, we spend less than 8% of the total healthcare expenditure for a disease that kills 30% of the patients. So totally unbalanced. And if you look within that number, the cost of innovative drugs that looks so expensive to the media, to the politicians, to the parliament, to the government, in fact is less than 0.7% of the total healthcare expenditure in France, less than 0.7% for anti-cancer drugs. So, is the investment on cancer treatment appropriate? Cancer kills about 30% of French people. It kills over 38% of people less than 65 years old in my country, but we spend less than 8% of the total healthcare expenditure on cancer and less than 1% on anti-cancer drugs. This is summary. And what are the lessons that we have got through these 5 years of National Cancer Plan? After I decided to step down and get back to my patient and to my normal practitioner life. The general political perception is that treating cancer patients is expensive because they think, the politician, that it is not worthy to treat these patients. What is the most expensive, I can tell you, is not to treat a cancer patient, but it's to let him die, because when a patient dies, it does not produce any economical growth. And for a disease that kills so many people, we spend much less than the burden of it represents. So in conclusion, I want to remind you, and this is my perception, is that a cancer patient should and have to remain a human being. That patients are different. You cannot speak about breast cancer patient or lung cancer patient, because even though they got this, what looks like being the same disease, in fact, a cancer, the word of cancer, the disease of cancer, cannot summarize the biography of a human being, of a French or any nation citizen. This was a woman before cancer. Then in a part of his life, she has had cancer, and if everything is good, she's lucky, she'll get back to a normal woman life. So she's not going to stay a cancer patient forever. And we cannot put all these people together just because they have apparently the same disease. And we know today, through the development of what we call personalized medicine, the gene sequencing, the gene profiling that tells us what kind of treatment each patient needs, what is the prognosis for each patient, because of this technique of gene sequencing, we understand that not only on the social and the political setting, these people are different and should be considered different and may need different treatment, but also their disease is different, and it is good that we consider not as a whole population, but each person as a human being. So I think I hope I've convinced you that cancer is a political matter. I convinced the government of France, so this is why we did National Cancer Plan with so much money and so much power within the hand of the National Cancer Institute, really to make progress and improve the outcome of each of the French cancer patients. Cancer control policies are critical. We have to control this disease. We have to set up global national cancer plan, and we have to improve the international cooperation through a world alliance of all people dealing with cancer. And I can tell you, the future is never written in advance. We can decide what's going to be. Thank you.
Bardzo dziękujemy.
Oh, thank you, Professor Kayat.
Pamiątkowy medal i
This is a token of appreciation in form of a medal, and many thanks for those illustrious remarks on the development of the world's first cancer plan in France.
Dziękujemy, panie profesorze.
Thank you, Professor, once again.
Medycyna paliatywna to
Palliative
jest bardzo
medicine
specjalny rodzaj
as a
opieki
very special
medycznej,
type
bo
of
pacjent także
medical care
jest bardzo specjalny.
because
Opieka nad
it involves
umierającym
also special
pacjentem
patients,
to
and
opieka,
caring
która angażuje całe człowieczeństwo,
for dying
opiekunów,
patients
personelu medycznego, lekarzy.
involves a lot of
Profesor Carlos
other human beings,
Centeno-Cortes
including
jest dyrektorem
families
Działu
and
Opieki
doctors.
Paliatywnej Szpitala Uniwersyteckiego w Nawarze.
Professor
W czasie
Carlos
swojego wykładu pan
Centeno-Cortes
udowodnił,
is
że
a
opieka paliatywna
professor,
to nie tylko opieka czy zaspokajanie
doctor in the
potrzeb
hospital in
fizjologicznych,
Navarra.
często
And
myśli się
in
o
his
to,
presentation, he will prove that
gdy nie można
care is
wyleczyć,
not
możliwe
about
jest uzdrawianie.
providing
O tym
for
mówić będzie pan profesor Carlos
the basic needs,
Centeno-Cortes.
but also about healing that arises from that opportunity. Professor, the floor is yours.
Dzień dobry. But this is one of the three words that I know in Polish. Other is Jankujen. And the another one is Woda Sodowa. Anyway, I'm very honored to be here. And I have to say to you, to all of you, congratulations for this extraordinary meeting in this loved country. I think that here that we can see is a joint of efforts, starting with the memory of this extraordinary person that it was John of Dukla. Your memory of the history, of the memory of the life of this saint, it's the best to congregate the people in this Congress to discuss an important issue as is the humanization in the medicine and in the world. And also we are doing that in an interdisciplinary way. And this is a value for all of us. Okay. In this presentation, the aim is to reflect of some peculiarities associated with palliative medicine and to outline what palliative medicine could mean for medicine. But keep in mind that my reflections are the reflection of a physician. I'm not a philosopher. I'm not an ethicist. I am a doctor that tries to reflect everyday bedside patient. It is important to note that in the first place, palliative medicine is special because the patient is special. The characteristics of a terminal patient or a patient with advanced disease means that they have special, peculiar needs. In addition, many professionals are specialized in end-of-life care, and they follow principles of the philosophy of palliative care. We are going to talk about that. But these professionals as professionals, we are very aware that not everyone can work in terminal care. And this requires a specific approach and involves their full humanity, which requires one to take care of themselves as a risk. Also, it has been said that palliative care serves to offer care when one cannot offer a cure. In this presentation, we shall study how it is possible to heal even when there is no cure. We will enter into the keys of this healing, the spiritual care that is offered by palliative care workers as many other professionals close to the patient at the end of life. To understand what palliative medicine means for the medicine, we have to understand first the patient, the palliative care patient. In general, it's a characteristic of the terminal stage of an illness that patients present multiple, intense, and variable symptoms. And normally, this situation is associated with a strong emotional element that affects both the patient and those that are close to them. But it's necessary to have a much deeper understanding of this type of patient. Fragility is one of the most characteristic aspects of the terminally ill patient. Frail can be defined as that which can easily be broken into pieces. The patient lives in an unstable world in which the smallest things can upset their equilibrium and lead them to require assistance. Both physically and cognitive fragility exist. The terminal ill patient is not only frail, but also very vulnerable, which means that defenses are very low. In physical terms, the deterioration in vitality is reflected also in the general syndrome or the general deterioration of the condition. In the emotional and spiritual spheres, the terminal situation becomes evident in different ways. The rules of the emotion are new at the end of life. Each patient will reach their end through their own personal experience of their illness. Nevertheless, it is important to consider that the terminal situation not only produces difficulties for the patient, but also it offers opportunities for personal enrichment and for establish even closer personal relationships. Anyway, the emotional instability and turbulence, the affective ambivalence, the rapid mood change are also characteristic in the psychology of the advanced patient. However, fear and anguish are usually also main components of the patient reaction. There is also a process at the spiritual level. For all patients, and in function of the conservation or not of the higher functions, the proximity of death provokes existential or spiritual needs that may become that most delicate and difficult than any other conditions. Nobody wants to die if they are well, and the natural reaction to the bad news of the proximity of death is rebellion. I don't want to die. Thus, it is often the spiritual care and the simple act of being there to provide companionship that helps the patient to die peacefully. I only want that is right. I only want to die without suffering. Cicely Saunders, social worker, nurse, and doctor, was the founder of the modern palliative care movement. Saunders dedicated her life to promote a new model of caring for terminal ill patients. In the book, The Management of Terminal Malignant Disease, published in London at the end of the 70s, reflects on the experience of a team that she brought together in the initial years of her work at St. Christopher Hospice. St. Christopher's was the first modern hospice established close to London in 1967 and founded after years of negotiation and in response to Saunders' personal experience and prayers. Thanks to the work of Saunders and to that of the many other pioneers in the field, palliative care today is considered as a new area of the medicine. In summary, the professionals of this discipline follow the concept of holistic care as their main directive for terminal care. Centered on the individual, excellence in systematic control and pain control, attention to the multidimensional problems affected by the disease in the emotional, spiritual, and social areas, and all of these elements combined in an interdisciplinary team aiming to alleviate the problems of both the patient and also the family. At this point, we can listen to Harvey Chochinov, who proposed to consider the A, B, C, and D of the medicine. With Chochinov, we think that the essence of the medicine is not in cure. Medicine does not to be in the cure, rather than in the A of attitude, you are important to me, in the B of behavior, you treat you with dignity and respect, in the C of compassion, move me to relieve your suffering, and in the D of dialogue, I listen to what you have to say me in order to treat you better. Is the A, B, C, and D of the medicine, published by Chochinov in The Lancet. In my perception, it's in palliative care where these essential elements of medicine can be seen better. What particular qualities does the palliative care professional need? Can anyone work in palliative care? What affects them and what helps them to overcome these problems? In the opinion of this author, not everyone is suited to caring for a terminally ill patient, or at least to care for them effectively. Bruera, a world leader of experience and prestige, resumed the issue by saying that to work in palliative care is needed to be very supportive and very compassive. The expression very supportive refers to the fact of being attentive to offer help, to be there and support whoever should need it. Cicely Sanders, in her conference, What's With Me, reminds us the words of Jesus in the garden, requesting the presence of his mother, dear disciple, that they should remain with him by his side in vigil. In these words, Cicely Sanders found the inspiration to dedicate her life to palliative care, being there, close to those that suffer near death. It is also necessary to arrive to the compassion. According with Chochinov, healthcare providers arrive at compassion through various channels. For some, compassion may be part of the natural disposition. For others, compassion slowly emerges with life experience, clinical practice, at the realization that, like patient, each of us is vulnerable. Compassion all may develop over time, and it may also be cultivated by the exposure to the medical humanities. Everyone can develop compassion through personal experience. Sometimes I hear, since I suffered that illness, since that happened to me, I can understand what the patients are going through, or the death of this close friend, or the illness of my father has helped me better understand the needs of my patient. These are my colleagues and sometimes myself. Anyone that offers care to a terminal patient with humanity and professionalism is offering palliative care, at least a basic level of palliative care. But also palliative care means specialized care. Then education, training, and experience are all necessary. Who wish to dedicate themselves to such care on a daily basis must achieve an advanced level of training and experience. But when caring patients every day, we need to looking after oneself to be able to care for others. Leading a healthy life is a help when working in palliative care. Outdoor activities, physical exercise, social interaction, free time, good diet, regular sleep, meditation, relaxed techniques, all are important elements of personal protection. But also, we have to remember that to care the spiritual life, the personal spiritual life, will permit the support of an essential source of vitality. When professionals with experience are asked what helps them to face the stress of the intense situation that they must deal with in palliative care, they tell the importance of leading a rich and ordered lifestyles. We can face the problems in our work on a daily basis, but outside of this environment, this should be compensated for with a rich or fulfilling home life. It is difficult to work with terminal patients without having one's own life in order, one's ideas clear, a life full of sense and meaning. Then medicine doesn't end in alleviation or palliation. It must still go one step further. We believe that the art of healing is always at the heart of the medical care. And that is the function of healing, the role of the healer, as to offer hope to a terminal patient in some sense, even though this may be only for a short time as a way to facilitate to die in peace. But healing is possible also at the end of life, in terminal care. To palliative care professionals, the paradox is evident each day. It is possible to heal, to cure the terminal ill patient, as explained by one of the pioneers, the Canadian Belfort Mount. I would like also to reflect more on this idea that is illuminating the palliative care professional. When we refer to healing, we are not referring to physical healing. That we call healing here is the qualitative change in life that leads one to adapt from the cessation of anguish or suffering to experience a sense of integrity, of full and profound internal peace. The concept of healing that has been used more recently in medicine is associated with concepts of personal fulfillment, integrity, and spirituality. Healing will be the personal experience of the transcendence of the suffering. This leads us to the last question of how to perform this art of healing. How can the palliative care professional help to heal a patient that is going to die? According with Sinclair, to cure others, to cure everyone else, it is necessary to use the professional personal qualities, including own values and beliefs, but also with other essential skills that can be acquired and practiced. The first one is the capacity to listen. This refers to listening attentively to details, a listen that captures the tone, the silence, the implicit message. It is an intuitive form of listening that seeks to understand the patient's true needs. With time, it becomes understood as an instrumental way of listening that is not the end in itself, but rather the means for something deeper that occurs in the interior of the patient, opening them to the transcendental and towards a transcendence. It is said that this intuitive listening requires the palliative care professional to become an instrument, to feel that he is not important, that they are the catalyst of a process, rejecting any desire of protagonism in terms of the care offered. When we listen in this way, delicately, we will permit expression of suffering, such, why me, I don't understand, I don't want to die, with relief to the patient. Second, we have to learn to look and to see. The look of the professional who wants to heal must be full of affection. It's a look that reaches beyond the patient, that searches for the essence of their identity, and that unconditionally accepts them and their problems. For example, we refer to the look of a professional that is independent of the level of consciousness of the patient or the capacity to express gratitude or a more positive attitude. We have to learn to look at what cannot be seen, to observe the characteristic imminence of spirituality, to capture the divine spark that resides in all patients. This look also reads the surroundings, the bedside table, the room, the religious image, or the photos that they have at the site. Third, we have to know how to care through words. Along with listening and watching, there is the capacity to participate in conversation, the capacity of talk. But what is most important about this is the ability to control the speech than to exercise this capacity, dominate the language. Those who trust strongly on their capacity to communicate tend to block the personal process of the patient, suffocate the therapeutic flow of conversation that the patient themselves might have initiated. And when words are necessary for the existential care of the patient, to heal them, it is fundamental to say little, and excuse me, not put your foot in it. We must bear in mind that communication through words is potentially damaging. Also, we have to care physically. In fourth place, the palliative care professional must cultivate the capacity of becoming physically close to the patient. Physical contact is also part of this important aspect of those who wish to heal, particularly empathetic contact, healing with affection, taking hold of the hand at the time of having a therapeutic conversation or during emotional moments. A care of the shoulders at the time of the bad news. This physical contact with the patient, when appropriated, indicates that there is enough intimacy to deal with more serious matter. The physical care of the patient, caring for their body, has an effect that goes out to the physical and that also affects their well-being. For this reason, we must be aware of the therapeutic capacity of physical actions able to contribute to the spiritual care of the patient. The way in which we approach the patient, the way in which we dress, the attitude of the nurse when enters in the room to change a drip or to leave a medication, a massage in the painful region during a wash, or any professional taking care of minor details of the room. All of these offer extraordinary help to the patient interior processes. And finally, the presence of the professional. The capacity of the professional to help heal in profound aspect can be summarized in the therapeutic presence of the palliative care professional. We refer to the presence of someone as that of the professional who approach with a true desire to help in this situation. The patient perceives that the present is genuine, immediately perceives that it's not only a doctor that is there, but rather someone who has came to offer help, that want to assist me personally, offering their true self, even being the doctor as well. To talk of the therapeutic presence of the professional is to refer to a presence requested. Don't leave me, be there, stay with me. Present is not to go to do something. Present It is not pass by, not even is to visit the patient. Present is to be there, to be part of the process of the patient, with the patient as he follows his own process. Moreover, is the presence of a vulnerable person, not only a doctor, but rather someone that will be affected by what happened to the patient and that will also be touched. In this feeling of vulnerability, affected by the suffering of the patient, there is something of sharing humanity. Yes, that affects me. I don't care that it affects me. And affects me, but I am still there. I'm not looking to distance myself, to put up a barrier, to shoot out this emotion. Also, I maintain my calm, that is also a tool. But it doesn't bother to me that I am affected, because the more that I am affected, the more that I can help the patient. The presence of the professional requires abandoning the role of the doctor or nurse that knows all, that has an answer for everything. We learn that at times there is no answer, that at times the only thing that is worthwhile is silence. And after an initial period of discomfort, it is possible to experiment how best to collaborate through your presence in the process of finding peace, of healing the patient. And this also contributes to the interior enrichment of the professional who grows, develops, and improves. In conclusion, that is the art of healing, which pertains to the true essence of the medicine. And we try to practice this in palliative medicine. Healing and euthanasia are not compatible. Moreover, when life finishes, there is a space for healing, understood as the experience of the patient in transcending their own suffering. The palliative care professional that wants to collaborate in the healing of the patient should approach this in their own way and develop core caring skills. And among these is the present as a human being, as a vulnerable individual, while at the same time being present as a professional. And in this way, palliative medicine could serve as a new paradigm for the 21st century medicine. Understanding medicine as the art of healing, a medicine where the doctor will not be a curer of diseases, but rather a healer of patients. Thank you very much. Dziękuję.
Bardzo dziękujemy, pan profesor Centeno-Cortez.
Thank you very much, Professor Cortez. Thank you for this lecture about palliative care, palliative medicine.
Profesorów za przybycie na nasz kongres.
So thank you for coming to the Congress.
Thank you. Gościem kongresu jest pan profesor Marek Krawczyk, rektor Uniwersytetu Medycznego w Warszawie, kierownik Kliniki Chirurgii Ogólnej i Chorób Wątroby Akademii Medycznej w Warszawie. Pan profesor Marek Krawczyk będzie mówić o rozwoju przeszczepienia wątroby w Polsce, także aktualnym stanie wiedzy na ten temat w Polsce i na świecie.
Transplants and current state of knowledge about this area.
Dzień dobry Państwu.
Good morning.
Kiedy pani profesor
When Professor Stanisławska asked me to participate during this meeting, this Congress devoted to dehumanization and depersonalization medicine, and to talk about transplants, I was wondering whether I should actually accept this invitation, but after a short while I thought yes. The title of my presentation, of my paper is here, The Development of Liver Transplantation in Poland Against the Background of International Experience. So transplantology in certain ailments and diseases, well, you cannot treat in any other way apart from transplants. The discussion whether we should take organs from dead people, from the deceased, can we do that when we transplant or take parts or whole organs, has been going on and will continue to do so. But I think many of those doubts have been dispelled by, well, in the middle of the 80s, at the these doubts were dispelled by St. John Paul II, who spoke at a Transplantology Congress, and he said, "What you are doing, what you try to do, helping patients taking organs from the deceased, is a beautiful deed and contribution of one person to another." And later in his letter, he expressed the same sentiment. And today, based on this, in the development, I will talk about the development of liver transplants in Poland against the backdrop of the developments elsewhere in the world. This is helping people who are ill, who can't be helped otherwise through surgery, radiotherapy or pharmacology. You need to give that person a new organ. So liver transplants began from Startl. This is the structure, the diagram presented by him, and you can only transplant a new organ into the place where it used to be. So this is into the same place. This is the transplant into the same place. You can see how vessels were interconnected anew, and it functions like a new organ. So that was the beginning of work of this young surgeon, his first experiments, first 5 attempts. The first attempts were not good. The knowledge at that time didn't allow us to accept this way of learning, of treating liver patients. So pioneers in Europe included Sir Roy Calne from Cambridge with the first liver transplant in 1968. Startl was the pioneer in the States in 1967, so it wasn't much earlier. Cyclosporin and the use of cyclosporin as an immunosuppressant was a breakthrough. It was really a landmark development that changed. It was a real game changer, and it was only 20 years later at the conference in Bethesda, which summarized that liver transplant is a clinical method, and this effect of cyclosporin changed the effects dramatically, because 1 year survival before that were at the level of 35%, and they immediately grew by another 30% once this medicine was introduced. So that was the Startl model, who shows that when you had 35% of survival before cyclosporin, and then you have yet another curve, and the best tacrolimus is the state-of-the-art medicine of today. So when do you decide to use transplantation? You can't help them all the patients. Not any patient with liver disease is transplantable. Those who have deficiencies of many organs do not stand much chance to survive. So This is the summary for the end of 2012. More than 100,000 transplants of liver in Europe, and Poland started in 1990 with the first transplants. And what is our history? This is the map showing the number of liver transplants in various countries. It doesn't show the current status, like any statistical presentation. The first experimental work were not initiated much later than in the United States. This was Professor Lubelskiej, who published his experimental research work in 1972, but only 1987 without good results. In Szczecin we had the first transplantation, and at the same time Professor Pardella in Katowice. We started in 1989, and then yet another milestone, more milestones of liver transplants in Poland. The first successful transplant was by Professor Kaliciński's team at the Children's Health Treatment Center. Yet other centers, we began in 1994, and then you had more centers present in Poland under performing liver transplant. Do we use all the organs for transplants in Poland? In 2012, the number of organs taken were twice as more as the number of liver transplants. They are not all good enough, so we don't use even those that we have out of many reasons. What is positive is that after this downfall in 2006, 2007, we are moving up again. The number of transplants is at the level of 15 organs taken per 1 million. The biggest number is in Spain, which is 30 per 1 million of inhabitants. What do we change? We accept marginal donors, rejected due to the reason of age, above the age of 55. When you have the high level of fat or sodium in donors, levels of AST and LAT were high that excluded transplantations before. This is the diagram showing taking of the organ. I'm not going to talk about the technology of this. This is the liver being prepared for transplantation. You see vessels interconnected in a moment. What is important in our country is the map of organs taken from the deceased donors, and you can see the changes region to region. In the west of the country, you have 22.5 per 1 million inhabitants of that region, and in the south of Poland you had none.
This map in 2013 has not brought those regional differences into equilibrium, but we have seen a situation improving dramatically. What are the current centers doing the transplant? There are 3 in Warsaw, 2 at the university that I represent. There is also one at the Center of Children, the Children Medical Academy. There are 2 in Katowice and 1 in Wrocław. The number of the liver transplants in Poland has been growing. Our data is much more current, up to date than what we have transmitted to the European register. By 2013, over 3,000 livers have been transplanted. per 1 million. The number of transplants per 1 million of inhabitants went up dramatically too. Does that cover our demand? No. We believe that according to, that in view of the current population, we should have 13 to 15 organs transplanted per 1 million of inhabitants a year. Those bars shows the number of patients waiting for the transplants. The blue bars are the capacities which we have and which are significantly smaller than the length of the waiting list indicates. What we deem a very positive development is that the waiting period for transplant has decreased, both for elective transplants and urgent cases, so we can help more patients. Also, mortality has decreased, so we can claim that we have made a great deal of progress in the Polish transplantology. For children and for adults, you can see the low bars at the level of 40 transplants a year for children. Professor Kaleciński and his team shows no mortality in the patients on the waiting list. So that means that almost all children that are still on the waiting list can be saved by transplants. In the adult group, the situation is not so good, but as you can see, the number of the transplant has been growing every year. What are the predominant centers? It has so happened that the center that I lead carries out nearly 60% of transplants in Poland. If we had another operating facility in our system, in our university, we arrived at the level of 80% of the transplants being carried out by the Warsaw Medical University. Here is the diagram of activity of the individual centers, and the blue bars show the dominating position of our clinic. As this result of activities, not only this is the outcome of a certain situation which exists if the centers are of greater or smaller experience. We answer pretty much every call. Only in certain cases we reject the transplant operations, and the fact that we dominate the number of calls results from what you can see on this slide, the acceptance rate of calls in our center. Here are our results of Poland vis-à-vis the rest of the world, and there is not much difference. 74% is the survival rate of 5 years. There are also grafts which show survivability rate of 70%. So these numbers are at least comparable, if not better, than in other countries. Maybe this is the outcome of the experience that we gathered from other centers as we implemented it to arrive at such positive figures. This is the clinic that I represent. And as you can see, till the 8th of October, we have carried out over 1,500 grafts or transplants, with 170 transplants every year. So this is one of the most significant results in the European statistics, and I dare to say in world statistics too. We use the same urgency scale. This is the so-called MELD scale, which is based on bilirubin concentration, prothrombin and keratonin. Most of the transplants are single transplant, but as you can see, over 60% of our patients were subject to several transplant or surgeries if the first organ transplanted failed. The indications in our system are very similar. There is this C virus sickness, and there are also other reasons. Here you can see the European data. There are 17,000 results from the liver diseases of various etiologies. Cirrhosis is leading the charts. And there is also viral cirrhosis. And the cirrhosis resulted from excessive alcohol consumption is in most cases the main reason. Also, the hypofunctions, paracetamol, suicidal attempts, also fungal poisoning is one of the reasons. We have saved the life of 2 patients only this year when we transplanted livers for them after they got poisoned with poisonous fungus. So the criteria of mushrooms, so the criteria are pretty much the same. Now, how about transplanting livers because of cancer disease? We have this internal liver cancer as the predominant reason, which develops on the foundation of the damaged liver. So since you represent oncological academia, we I can recall that cancer is one of the main indications. Why is cancer not a good indication? Just because transplantologists are pretty good in determining patients who qualify for transplants. Mazzaferro published a paper on the qualification of patients to arrive at the better 5 years survivability results. And these criteria have been extended a little bit nowadays. The same surgeon published another paper in 2009 where he expanded the qualification criteria on the patients with the so-called up to 7 criteria. That is about the number of tumors. We have also contributed to this presentation by sending our qualification results. We have also published in the World Journal of Surgery another letter dealing with a certain marker which can be helpful in screening the patients for liver transplants. This publication found a very good resonance amongst the transplantologists and oncological surgeons. The Milan criteria indicate that if they are met, the results are much better. But we also treat the patients who don't meet those criteria because we often use the radiological, radiotherapeutical investigation, which is then corrected by the morphologists. The up to 7 criteria are also a qualifying factor for the patients. Another indications, cystadenocarcinoma. Sometimes, yes, but they don't yield a good treatment effects. Yeah, you can see we can see here the picture of those organs that have been transplanted, and we have a lot of cases of metastasis there. Survivability, according to our data, are quite comparable between Poland and the European statistic when the patients and the grafts are concerned. What improves our statistics, not only in transplants, but also in general surgery, is the experience of the team. You can clearly see that the survivability after 2007 is much higher than before when we started launching the program. The same happens to survivability of the graft. Also, survivability of children is great. You can see 50% of the transplants come from the living donors, the rest from deceased donors. And finally, when we talked to Professor, the editor of the publication of this conference, when we started taking livers from the living donors, we used experience from the failed experience in Brazil and the successful one by Strong in the US. In 1999, the first successful transplant occurred in Poland. Here is Professor Kaliciński holding a part of a liver taken from the father of the child subject to the surgery. This child is still alive and living well. Here you can see further examples of the liver samples that were taken in our clinic before the transplantation. They are smaller than the palm of the surgeon that who reattached the liver, and then you can see the liver after the transplant and those small children that we saved of whom we saved lives. In the most cases, the donors are parents, predominantly mothers, fathers to a lesser extent, or adult brothers and sisters, or further next of kin, such as grandparents, if young enough. So there are many segments from the third to the eighth, and here are the results of liver transplantations in children by Professor Kaliciński. These results are very good. And the combination of humanization, personalization of treatment and medicine, especially when father or mother or the next of kin, in attempt to save the life of their child, help it by donating fragments or parts of the livers. This is something very good. It's much better than when we take livers from the deceased person. This is an adult daughter who were donated with the right part of liver from her father, and you can see the picture from the computer tomography, which shows the volumetric segment before the transplant, and you can see the graft, and then you can see also the left-hand side part, which stayed in the father's body. So both are very much alive and healthy. So we do not see any threats to transplantology programs in Poland. We will try to increase the number of available organs and to to set up more centers of transplantology because the waiting line of the patients is much longer than the capacities that we can offer. Thank you very much for giving me this opportunity to offer you this lecture. Oh, thank you, Professor. We congratulate on tremendously good results, and I think that we can rest assured that the transplantology programs in Poland will develop very successfully thanks to a great and successful team around the professor. Now, let me announce a coffee break. We reconvene at 12, maybe 12:05, to continue with the next part of our presentation. Thank you, and see you at 12.